Good afternoon. My name is Dr. Jean Creasy, and I have the pleasure of hosting this webinar this afternoon on prevention-centered success. I've been a private practice dentist for about 20 years. Before that, I was a dental hygienist. And for the last 6 years, I've been involved in academia, teaching at the University of Pacific Degoni School of Dentistry in the Bay Area. And most recently, I've become a part of the faculty at California's newest dental school, California North State University in Elk Grove, California. My conflict of interest statement consists of the fact that I have served on the National Canberra Coalition Board of Directors, and I am a shameless cheerleader for all things dental prevention. I'm also a big advocate for improving health communications. So you'll hear me promoting those two interests shamelessly throughout this webinar. Our learning objectives for today is to understand why focusing on prevention works both for patients and the practice. It's to understand the basics of caries risk assessment and how to fight the acid challenge. We're going to explore the logistics of utilizing risk assessment in the real world. And finally, we're going to discuss the communication skills needed to coach behavior change in patients and in your practice culture as well. A little bit about my current practice. I live up in a small town, rural town in Northern California, Nevada City. I've been in private practice with my husband. He's been a dentist for 38 years, and I joined the practice after my hygiene career. We've been married since we were both undergraduates, so been together forever, and we have a practice partner. So there's 3 dentists you can see in the picture there, and we have a wonderful big staff that's been with us forever. I truly love my profession because there's so many opportunities to smile, so many opportunities to do different things. As I mentioned before, I'm now part of the faculty at California North State. I hope any of you that come to the Sacramento area will pop in and see California's newest school. I'm also very much involved in global health outreach, specifically in the country of Uganda, in a rural area where I've been doing outreach for the last 15 years. So while dentistry is wonderful and I love it, we need to recognize that it is a tough profession. And that's part of my motivation for focusing on prevention. It actually makes my job easier. So we're going to talk a lot about caries management by risk assessment. And you might ask yourself, if you're in private practice, why does this stuff matter? Why don't we just repair the disease, the process of the disease, repair the decay, repair broken teeth, try and treat caries? Why are we looking at this? The fact is that adult caries is on the rise. It's actually decreasing in children, which is fabulous news. And that's probably because of good prevention care, the use of fluoride varnish routinely, and all the expanded access to care that's gone on in the last, I'd say, 25 years. There's been a huge increase of access to care for children. Unfortunately, 92% of all US adults have some form of dental decay, and nearly 1/3 of US adults have untreated caries. And that's a lot. And I think there's still a lot of misinformation on behalf of patients and maybe sometimes even providers as to the susceptibility of adults towards caries. I'm sure it's multivariable in cause. Another reason that focusing on prevention is important is that patients are actually more focused on prevention. I'm sure many of you have been to the gym lately and seen all the people that take advantage of what they call the silver sneakers benefit through Medicare. And it is just not uncommon to see quite a number of elderly people at the gym working out, and they can put me to shame, that's for sure. Maybe doing maybe doing yoga positions I could never achieve, or lifting weights I can't do. There are actually fewer smokers than when I was growing up, thank goodness. There is more lay medical knowledge out there. When any of us have any ailment, we quickly go to WebMD or we Google all sorts of information. So there's actually a lot more knowledge out there. that leads us to seeking more healthy lifestyles and a definitely conscientious eating choices. There's concern about, there's a lot of talk. I'm very active in organized dentistry as well. At one time, I served on the Council on Dental Practice for the American Dental Association. And when I served on that council, we talked about things like accountable care, outcomes-based medicine, diagnostic codes, and risk assessment codes. These are all things that have been at play within the medical field for a number of years, and they've just come over to dentistry in the last couple years themselves. So you need to be on the lookout for the requirement that we use diagnostic codes, and they're actually very helpful, especially as more and more dentists practice in group settings, community clinics, and as well as corporate dental settings. When more than one provider is seeing a patient, using a diagnostic code so the last person knows exactly what you saw is very helpful. And then risk assessment codes are also very useful because it helps identify where the patient is at a certain point in time with their risk. These all come into play with regard to insurance companies, because insurance companies are talking about the outcomes-based medicine, outcomes-based dentistry. They can come into your office and want to do a chart audit and look at how you are assessing risk. I'm not a big fan of regulatory issues, but I will tell you that about 10 years ago, we had a Delta insurance audit, and they came in and they looked at our charts, and I felt very validated because they really liked that I was entering into the patient charts their risk assessments for both caries and periodontal disease. As you can imagine, because I practice with my husband, there are times when we don't agree about the way to do things. And it felt very validating that I got a little pat on the back when the Delta auditor saw my risk assessments entered into the new patient exams and into the recall exams, and my husband didn't have them. So that was a gold star for me that day. So I really feel like prevention is what dentistry is all about. After all, we have been a prevention-focused profession for as long as I've been associated with it. And I think it's something we can all take pride in. We are not just repair people, we are oral health coaches. We really want our patients to have their best oral health possible for all of their life. And when we approach our work this way with that higher purpose, it really does help us avoid burnout. Nobody wants to do the same thing over and over each day. And if you did filling after filling after filling all day long, you would be burnt out. And so it really makes our lives a lot easier when we have a prevention focus and we look at each case individual uniquely as if we were dental detectives. There's nothing more discouraging than watching our restorations fail due to recurrent caries. And patients who choose prevention really do make our life much easier. I'm sure any of you who have been in practice for any number of years have seen something that you placed using the best techniques fail because the patient had uncontrolled caries. And we put so much emphasis on doing technically perfectionistic work, but no matter how good the crown margin or the restoration margin is, no matter what kind of perfect technique you used, if a patient's decay burden, their caries burden, is so high and so challenging, even that will not work. Dentists don't want their patients to experience pain, and we don't want to experience pain either. We don't want to experience the pain that comes from doing the same thing every day. We don't want the pain from not meeting our overhead costs. We don't want the pain from seeing our work fail prematurely due to caries. And we don't want the pain from seeing patients unable to control their dental disease. And we certainly don't want the pain from dissatisfied patients and no referrals. I think focusing on prevention is a win-win-win for both the patients and the practice. We're going to talk about why it makes sense to focus on this. We're going to paint a portrait of what a successful prevention-centered practice looks like. And I'm going to walk you through the logistics of how to make a culture change in your practice. My history of being a preventadontist, I'll say, started when I became a dental hygienist in 1983. I then went into private practice with my husband, and I was also a community prevention program coordinator. And what I saw when I visited the schools back then, this would have been in the 80s and early 90s, was that there was a lot of caries out there. I wanted to do something about it, and I felt called to go back to dental school. So I had to go back and retake all those miserable courses like calculus and physics and trigonometry and all the G-Chem and the O-Chem. It was really quite a challenge. But at least I thought, if I get into dental school, there's going to be some things I know already from my hygiene background. And what I knew from hygiene school, this was dental prevention circa 1983. I'm sure many of you weren't even born yet, but it was very simple. Eating candy causes cavities. Brushing your teeth prevents cavities. Flossing your teeth prevents interproximal cavities and gum disease. And people with excellent oral hygiene don't get cavities. So this is what my foundation of knowledge was when I started UCSF Dental School. I matriculated at UCSF in 1997. And one of my educators, who then went on to be the dean of the UCSF School of Dentistry, was he'd actually gotten his PhD in physics, I believe, but he made his whole career out of studying fluoride. And he was a very influential dental educator and has become what I'd call the godfather, along with Doug Young, Dr. Doug Young, the godfather of Canberra. And he introduced me to, Dr. Featherstone introduced me to the concept of caries management by risk assessment. It's really looking at each patient uniquely, identifying who is most at risk. It's coming up with an action plan for their treatment, and then it's monitoring their care to see if their caries risk is under control. This is the new thinking on caries prevention, that caries is a biofilm-mediated disease. We need to really alter the biofilm. We need to alter the type of bacteria that are proliferating in your mouth. All biofilms are not created equally. Caries disease is a pH-mediated process, meaning that it's very much related to what the pH of the oral environment is, and teeth essentially are melting in the presence of a low pH. Antibacterials can help reduce the numbers of acid-producing bacteria. Carbohydrate frequency is more important than quantity, and we'll talk more about that. It's how frequently you ingest carbohydrates and not how much you are ingesting. And acidic environments promote acid-loving, acid-producing bacteria types, which is just so interesting. So if your oral environment is always at an acidic level, you're selecting for acid-producing, acid-loving bacteria. So it turns out your mother was absolutely right, which we all hate to hear. And I would put the asterisk that your mother was right, at least with regard to bacteria. You will be influenced by the company you keep. I don't know about your mom, but my mom was always like, you should be careful how you pick your friends. Don't pick troublemakers. So changing the biofilm is a little like gardening. You don't want to feed the weeds. And when I say feed the weeds, if you constantly bathe your mouth in a carbohydrate fluid, anything, it can be healthy food like a banana, or it could be junk food, sugar, that will feed the weeds and grow the acidic bacteria. So how can we influence the oral microbiome? You have to get rid of them. So when I graduated from UCSF, I was a true believer with lofty ideas. I had big plans for eradicating childhood caries in my community. I wanted to change the paradigm, but that was no easy task. You think if you just give people information, they will jump at the chance to take your advice, but it turns out that that's not really the case. It's a little bit like fires in my area. I live in Northern California. We have a lot of wildfires. And when there are this many fires, as we all know from the past few years, we can never have enough firefighters. So it's not just us as dental providers out there trying to fight caries and trying to make an impact. It takes prevention. It's much better to have an effective prevention program. And it's really only the patient who can prevent decay. So prevention turns out to be an idea I found in private practice that really resonates with patients. It really places the power in the patient's hand and creates an ownership of oral health outcomes. It offers a good return on investment for the patient. It leads to less need for restorative treatments, which saves money, saves time, saves pain, and it maintains health, function, and aesthetics. I always say a well-kept smile is the best kept beauty secret. Prevention-centered care is also good for the practice because I can tell you that it creates a goodwill that patients do tell their friends about. It builds lasting and loyal patient-practice relationships that focus on maintaining health versus treating disease. And it demonstrates a professionalism where the patient's oral health interests, not the practice profit margin, are the driving force. When you, from an ethical standpoint, when you put the patient's oral health interests ahead of the practice profit margin, you sleep better at night. And trust me, you will do just fine financially. It creates staff retention because your staff see where your focus is. They like those values. They appreciate not working in an office that upsells or really just sells dentistry. And it creates a very healthy recall system. This is a little image of my practice in downtown Nevada City, my home sweet dental home. And we are looking for an associate or a buyer. So if you know of anybody, I think my husband and I are very much ready to retire. I'm going to tell you about what my new patient exams look like. And I think I could be a new patient specialist because I enjoy it so much. And my new patients tend to really enjoy it as well. It's not unusual for me to get a hug at the end of a new patient visit. So it's all about the patient really, and people like to tell you about their past experience with dentistry. I spend a lot of time assessing their individual risk factors for disease. So my number one job is establishing rapport and trust. I ask about their past experiences. I do a little sleuthing into their diet in a very non-judgmental way. I want to know about their overall health, what medications they're taking, I'm trying to assess their oral health literacy. I'm looking for behaviors and practices that might influence their caries rate. And also I talk to them about their familial patterns and attitudes. You'd be amazed at some of the myths people have about their own oral health that they might have heard from their own parents, or they might say, everybody in my family has bad teeth, and they feel like that they are completely unempowered to do anything about it. I look at their existing restorations, their plaque levels, saliva flow, and I utilize motivational interviewing, starting with listening first. I feel like the new patient exam is a golden opportunity. This patient, just to get into your chair, has overcome various psychological barriers. They might be fearful of the pain of being in a dentist's chair. They might be afraid of how much it's going to cost. They might be afraid that there's going to be a certain amount of shame involved if they haven't been in years. So they have overcome all these barriers. So it's really up to us to value their presence at that new patient appointment and make them feel very welcome. I want to paint a picture of what's in it for them. I want to paint a picture of what their oral health could be like in the future, focusing on their individual motivators. Is it less fear, less pain, less treatment, fewer expenses? I want to paint a positive future for them. And there's always a way back to better improved health, and really reinforce that vision of improving health. I think it's time well spent when we take the time to listen and say things like, is there anything else you're concerned about? Do you have any other questions today? Asking things like that really clues them in that we have the time to listen. It's part of establishing rapport. And I do take the time to tell them a little bit about our practice and our focus on prevention, so they know what my expectations are as well. We talk about them and their own power over their own oral health. And I take care to be reassuring and reflective. And I try to educate while I'm evaluating. So that means when I'm going around and calling out the restorations to my assistant, I will comment on what good I see. I'll comment on the areas of concern. When I'm doing the pocket depth readings with my probe, I make sure that I let them know what I'm doing and why I'm doing it. Raising someone's oral health literacy to a higher level is a real priority. How do I justify the amount of time I take with new patients? I once read in Dental Economics magazine that the average dentist pays about 6% of their gross collections on external advertising. And that's despite the fact that most studies show that 80% of all new patients are referred from existing patients, so word of mouth. And yet somehow we feel like if we just pay to have advertising out there, it's not that advertising doesn't work, but the amount of, if you can create word of mouth referrals, that's even more powerful. It's the best marketing tool that money can't buy, is actually our time. Taking the time to coach our patients towards their best oral health. They really value it and they do tell their friends. So let's talk about Cambra. Let's talk about caries risk assessment. Let's talk about prevention science these days. So we know now that the protective factors we are trying to encourage are saliva flow and its components. We're trying to encourage and offer more fluoride, calcium, and phosphate to enhance the remineralization process. We want to encourage antibacterial use, chemotherapeutics for our patients that suffer from caries. The pathological factors we're going to talk about are the acid-producing bacteria, the challenge of frequent eating of fermentable carbohydrates, and what happens, the catastrophe that happens when there's subnormal levels of saliva flow and function. So to dive a little deeper in the pathological factors, there are actually multiple acid-producing bacteria. We used to really focus primarily on strep mutans, but now we know there are several acid-producing bacteria types that are proliferating in an acidogenic environment. Really helping our patients understand what fermentable carbohydrates are, that again, it can be something like fruit sugar, milk sugar, simple sucrose sugar, or crackers, pretzels, starchy foods. We want them to understand the burden that orthodontic appliances place on our ability to clean teeth. If you happen to wear orthodontic appliances or even partials, how the clasps will retain more plaque. What exposed root surfaces, why are exposed root surfaces more prone to decay? Simply because they're not as highly mineralized. We want them to understand that in an acidic environment, their teeth, they're literally melting, and why low saliva flow is a problem. This all leads to demineralization. When the pH is lower, when there's an acidic environment, your teeth are literally dissolving. And using that verbiage that your teeth are melting is actually pretty powerful. Patients really get that. So this is what we see in demineralization. I like to use pictures to show my patients, and showing a picture of bricks going from brand new to kind of worn down really helps them get a feel of what their enamel is doing during demineralization. Clinically, it appears like white spot lesions, and you might see this on your own teeth or your children's teeth if you're looking, and definitely on your patients. The protective factors, again, are saliva. I promote a lot of diet and oral hygiene counseling. You have to do it very carefully. Nobody likes to be told what to eat, and people get extremely defensive when you start talking about their diet. I use a lot of fluoride varnish, extra strength fluoride toothpastes, and I promote my staff applying them with generosity. We use, and when I say generously, almost every patient is a good candidate for fluoride varnish. And we also promote antibacterial therapies such as chlorhexidine, sodium hypochlorite, the use of xylitol products. Let's talk a little deeper about saliva, and it truly is a wonder fluid. The more they've identified numerous fantastic attributes to saliva. The components are much more complex than was thought probably 50, 60 years ago. There's proteins. These are a few of my favorite fast facts about saliva that you can drop at the next social gathering you're out. If you really want to command the room, just start talking about spit. They have histatins and proline-rich proteins, which contribute to building the pellicle, which you know is that wonderful protective layer on the outside of our teeth. There are special proteins that maintain the supersaturation of calcium phosphate. These are the stathrins, and they're like carrying around little bags of calcium and phosphate to be present for remineralization. There is calcium and phosphate itself that help inhibit the demineralization and enhance remineralization. There is bicarbonate that helps buffer the acids. And that when you think about it, since none of our saliva is exactly the same, it helps explain why some people, their saliva is more protective than others. The salivary components are capable of carrying fluoride when it's available around the mouth. And saliva also has antibacterial properties, certain special proteins, the histatins and the cystatins and lactoferrin. And I believe also IgA, which is also found in tears, is present in saliva. So when you're doing your new patient exam or a checkup, it's important to assess the saliva's viscosity. It should be nice and watery. Stringy or bubbly saliva is less helpful. And low flow saliva is seen in patients. It looks kind of thick and frothy. It could be medication induced. It might just be because they're nervous, and it might be because of Sjogren's. And I hope you're all familiar with Sjogren's syndrome and the effect that has. And I have to say, I'm seeing more and more of it as I've gone through my career. In the early days, I did not see any or very few cases of Sjogren's. And these days I see it much more regularly. I could probably count 6, 7, 8 patients in my practice. And I think they've just gotten better at diagnosing it. So saliva is key. And I often think there's a really funny phenomenon about dental patients and saliva. I don't know if you've noticed this, but when they sit in a dental chair, suddenly they become just horrified by their own saliva. There's just some patients that are like this, and they insist that you suction it all out. And my assistant and I laugh about this because you wonder what they do with their own spit when they're not in your dental chair. They don't have a little saliva ejector or suction tip with them, so they must have to swallow it. So I've yet to figure out why they find it so disgusting when they're in the dental chair. We are going to take questions at the end. And so, yeah, go ahead and enter yours if you don't want to forget what it is, and I'll do my best to answer it. So some of the protective factors about fluoride, I always think of fluoride as poor, misunderstood fluoride. He's so often maligned. I'm sure you have all come across patients who have read too much misinformation on the internet about fluoride. And it's our job to help tell them about the benefit of fluoride and why it works. So most powerfully has an anti-caries effect by its topical and antibacterial effects. We used to think years ago that the systemic effects were the most powerful, but it turns out that they're really primarily topical and antibacterial. The therapeutic levels of fluoride can be achieved from drinking water and fluoride products, so the use of toothpastes and water if the caries burden isn't too much, if the challenge isn't too much. But as I say here, that fluoride therapy may not be enough to overcome a high bacterial challenge. Again, it works primarily a topical mechanism. And so that's why fluoride varnish is such a wonderful enhancement. It inhibits the demineralization by absorbing from solution onto the tooth mineral crystal surfaces. It's like building stronger bricks, making the crystals that form your enamel tougher and harder. Fluoride enhances remineralization by actually combining with calcium and phosphate to form a fluorapatite-like remineralized veneer. So it's like putting a stronger surface on your enamel, and it is stronger than the original enamel, which is pretty cool. Here's something that I do in my practice. When you see a class 5 lesion, if it's not too deep, and the patient, it's not really bothering the patient aesthetically, I really prefer not to fill it, because I've found that if I fill it, it's more likely to get recurrent decay, because the patient can't, if there's any leakage over time, especially in a high risk patient, I would prefer to apply some fluoride varnish to these areas about every 3 months. And then if they really need it filled, or maybe you have placed a GI restoration, what about recharging it with fluoride varnish? I think there's some good research coming out now that really supports this recharging a glass ionomer restoration with fluoride varnish. So let's talk about remineralization. This is what we're all hoping for: calcium from our saliva, phosphate from our saliva, remineralizing along with the fluoride to make that tooth even stronger than it was before. Fluoride actually helps to speed up the remineralization process. This is what we're hoping for, going back, and I have seen this radiographically. I was just with one of my other Canberra icons, Dr. Alan Wong from the University of Pacific, this last weekend at CDA Presents, and he was showing me pictures, some images that one of his residents had done of where they tracked it radiographically, what was a class 2 caries lesion being remineralized by using fluoride varnish, regular fluoride varnish applied with proxy brushes. And it was amazing to see this. It was a very cool little time-lapsed photography. Restoration alone is not the cure. We really have to change our way of thinking. When we fix a tooth, it is really very similar to putting a new roof on a burning building. You have to extinguish the flames. You have to treat the disease in order to stop it. So I'm going to run you through the logistics of what I do in my practice here. One of the key things to assessing the risk assessment for caries in a patient is finding out where they're at. And there are many forms that you can use or lose. Once you get very comfortable with this, you'll have to find your own way of doing this. And there are many forms you can use. I know that Centrix has some great forms available that you can download off their website. The ADA also has some very good forms, and it's to figure out and you can also have patients fill out these forms while they're waiting, and that's very impactful to engage them in their own oral health assessment. You can ask questions like, how often do you snack? Do you take any medications? And there'll be ratings on the form so they can see for themselves. You have to decide within your practice, do you complete it with the patient? Does your staff, does the patient do it themselves? You'll find, again, a practice that works well for you. Here's an example of the Centrix self-assessment form that a patient could be filling out while they wait for the hygienist to get them in between, while they come and they're sitting waiting. And it's very simple and it's easy to understand because of the colors. So if you do a clinical risk assessment, which you have to do as well, you're looking at their existing restorations. You're assessing the age of the fillings. You're looking at their the fact that they have orthodontic appliances. Is there any current active decay? If they have current active decay, this automatically puts them in the category of being higher risk. Do they have any early lesions? Any presence of plaque, saliva levels? You're looking at if there's a little pool of saliva pooling under their tongue as you do their oral cancer screening, that's a very efficient, clear way to know how much at risk are they at. It's important to have a conversation to find out where they're at. What type of work do they do? Are there any signs of erosion? Do they have, again, adequate saliva levels? Are they frequent snackers? Acidic foods? You're basically acting like a fortune teller. You want to interpret the signs of today to see the symptoms of tomorrow. And here our fortune teller says, I see the future of your oral health, and it doesn't look so good. If your patient has a low risk for decay, they can do exactly what they've been doing. You tell them to continue to brush 2 times a day with a fluoride toothpaste, and whatever else they're doing, it's working. And they can come back in for cleanings depending on their periodontal health every 6 to 12 months. I mean, again, we have it in our mind that they have to come in every 6 months. Some patients that have excellent oral health maybe only need to come in once a year. For the moderate risk protocol, you can do 2 times daily, continue with brushing fluoride. You'll want to get into some nutritional counseling, which we'll talk a little bit about. You want to encourage them to chew xylitol gum or mints daily, a couple times a day. You don't have to make a career out of chewing the xylitol gum. I think it does what it needs to do within 3 minutes. By the time it loses its flavor, you can spit it out. You want to encourage your moderate risk patients to rinse daily for 1 week every month for the next 6 months using a antibacterial mouth rinse. And then you want to do a recall at 6 months, definitely with a fluoride varnish application, and repeat the risk assessment and see if they've made any progress. Once applied, the fluoride varnish, this is your extremely high risk protocol. And with these people, this is anybody that has had that has inadequate levels of saliva. Did I miss? I guess I almost say anybody that's high risk is really high risk. So with the extremely high risk patients, you are fighting an uphill battle, and you're going to have to be very persuasive in getting your patients to comply with the changes that are needed to reverse the damage and to get them into a lower state of risk. You want to apply the fluoride varnish every 3 months. You want to have them do an antibacterial mouth rinse, either a sodium hypochlorite based mouth rinse like Carefree, or you want them to use, some people like Paradex. I personally think Carefree or the sodium hypochlorite is much more effective. You want them to be brushing at home with a high part per million, a 5,000 part per million fluoride toothpaste daily to enhance remineralization. You want them to consider using xylitol gum or mints 4 to 5 times daily. And you want them to even possibly consider carrying around a water bottle with a little tiny bit of baking soda in it to help lower the pH. And you might want to have them consider using the type of toothpaste that not only has the high fluoride, but maybe a one that has the nanoparticle calcium and phosphate in it. And then you want these patients, the high risk patients, to be on 3 to 6 month recalls. Something new to consider on your high risk patient, which is anybody that has an active caries, they are high risk for more caries because you know that acid environment is present in their mouth and melting their teeth. Something you might want to consider doing when they've had a restoration placed is to apply some fluoride varnish immediately at the point of after you've placed and polished this restoration, gotten it all where you want it to be, is to leave them with a little fluoride varnish in place. If it's a glass ionomer type filling, it will actually absorb some of the fluoride. It'll charge it up. And even if it's a composite restoration, it's starting them off on the right foot with extra prevention. It's quick and it's cost effective. So what now? Maybe you've decided, maybe you're listening to this webinar and you're like, I really want to change my practice to be more prevention focused. I want to get my team on board and I want this to happen. Well, it turns out that changing the mindset of your team and your patients can be like pulling teeth. And these little talking heads or thinking heads say, the one says, let me tell you what I think about all the changes you're going to make. Let me tell you about that. And the other person is saying, I hear your words, but I am not ready to make any change, especially if it means more work for me. I don't know about you, but that's the way it is in my office, or it has been. So how hard this can be. You're a believer too now. You're the leader of your team. How are we going to implement this change? Here are some of the problems: is that people don't see your vision. They don't actually listen well, it turns out. People won't ask the clarifying questions because they think they'll look stupid if they don't understand what you're telling them to do. People don't desire change until they are internally motivated. Until they become true believers, they will not want to change the way they're doing things, the way they're comfortable doing things now. And there are sometimes in a dental office, there can be hidden hierarchies. We know this is true. There's politics in most offices that can undermine successful change. So things that will help work in your favor, you have to ask yourself, how committed are you to this change? Do you have a solid plan? Will you be able to delegate defined tasks of who does what? That your office manager will take care of this part, that your hygienists and assistants will do it this way? Do they see your vision? And can you paint that vision in 3 different ways? Because you have to allow for different learning styles and different accommodation styles. And then repeat that, because you do have to repeat yourself. No, this is how we're going to do it. And be prepared to take small steps towards change, small steps forward, and then go back and reinforce that messaging. Initiating culture change is easier than it sounds, and that's why I give you these tips. The main reason we human beings avoid change is fear. And we need to make sure that everyone understands the why of why we're focusing on prevention, why it's going to make the practice a better place overall, and what is the need for the change. And it's really helping our patients achieve their best oral health, which is going to lead to practice success. And it's actually going to help lead to better job satisfaction and the pride of a job well done. It's going to help build relationship-centered practice that is a successful practice, I can tell you. So what is your goal? Can you describe it? Can you initiate a more robust prevention coaching program? And can you track the products? If you're using things like xylitol gum or using fluoride varnish, can you track whether or not your utilization is really going up for your patients? Make sure you can name the steps of initiating change, of who does what. And then make sure you look critically to see if you can identify the stumbling blocks, the resistance that comes up. How will you measure this success? To increase, will it be an increase in the practice statistic, like the utilization of your fluoride varnish or your risk assessment codes? So what's next? You need to establish a time frame, evaluate the metrics for success, go back and revisit those practice influencers and get feedback for the improvements. See what stumbling blocks they've come up against. Changing patient behaviors is like waking up patients to their own caries risk factors, and you really have to tap into their internal motivators. No one ever makes a behavior change in how they care for their oral health if they don't feel motivated to do it. It turns out that I've been doing some work with UC Berkeley in their oral health literacy program. And I was shocked to find out that there's so many people that the number of people have low oral health literacy. 93 million adults have basic or below basic reading skills. The lowest two levels cannot use a bus schedule. I mean, this is a big piece of the pie here. They can't read a short set of instructions and identify what is permissible to drink or not before given a medical test. So this tells you where a lot of your oral hygiene instructions are going, right over a lot of people's heads. So this, the group I'm working at UC Berkeley with is called HRA. It's part of a California Department of Public Health initiative, and it's called the Oral Health Literacy Toolkit. And I encourage you all to look this up, Oral Health Literacy Toolkit through California, state of California. And it's really a fabulous, simple tool you can use to improve your communication skills on oral health in your practice. So here's some tools I use for balancing the acid challenge. I've mentioned many of them before. The high fluoride toothpaste, buffering sprays such as Boost that are little atomizers that you'd carry in your purse or wallet or pocket that you can just spray in your mouth and they lower they raise the pH. Frequent recalls with fluoride varnish, use of xylitol gum, mints, meltaways, antibacterial mouth rinses, oldies but goodies, the toothbrush and floss. So what about antibacterial rinses? Let's talk about this real quickly before we run out of time. Who should use them? Your high-risk patient. And these are people who are unable or unwilling to quantitatively improve their oral hygiene. And this is a lot of different people. You can have anywhere from a physician in your practice to a, an unemployed person that's, just barely making it by. It does no reflection on their IQ. They just can't control their biofilm levels. It turns out that sodium hypochlorite is actually a very effective antimicrobial. And yes, that is like swimming pool water. It's bleach. There's a lot of benefits to sodium hypochlorite. It's broad spectrum. It actually reduces the caries index. When it was tested against a placebo fluoride rinse, which lowered the caries index by 29%, the sodium hypochlorite mix lowered the caries index by 73% over a 3-year period. So that is pretty remarkable. And it actually dissolves the biofilm and kills the bacteria more efficiently than a lot of other things. So it's a pretty powerful tool. You can mix it at home. You can homebrew mix it yourself. You take 2 teaspoons of sodium hypochlorite, which is household bleach, and you mix it fresh in an 8-ounce glass of water. And this yields a 0.2% solution. You want to rinse with this 1 minute, 2 to 3 times a week, and you'll feel your biofilm change. The problem is it tastes bad. So there is one you can get probably through Amazon. It's through the Carie Free company, and it's flavored. So you mix it fresh, again, part A and B. It is tastier than home brewed. So xylitol fast facts, for any of you who are unfamiliar, it's a 5-carbon natural sugar. They find it in strawberries and birch bark, I think. And it looks like sucrose, and it has about the same sweetness by weight. A lot of people will put it in their cooking, but it's not cariogenic. The cariogenic bacteria cannot feed on it. They think they can, so it's almost an antibacterial thing. And it's actually thought to be a very effective preventive tool, and they use it in medicine as well. There's some thought of using it as a nasal spray as a antibacterial. Humans can feed on it and use it as an energy source, but the bacteria can't. I talk about diet a lot. You really need to get comfortable with talking to your patients in a non-judgmental way about their diet. I happen to be a kind of a latecomer to believing how detrimental even fruit sugar can be. And I became such a true believer about the power of sugar to cause caries when I did some research in Africa. I did a dental health screening on some very remote people, the Batwa Pygmy, who live in Uganda. And what I found amazed me. I was the first dentist ever to do an oral health survey on this population. They have no access to dental care. And I was shocked at how healthy their mouths were. I've never seen so little decay. So it really gave me an appreciation of the power of no fermentable carbohydrates in their diet, no access to sugars and candies. Their teeth were just amazing. Unfortunately, Coca-Cola has too discovered Uganda. And so I'm sure as I continue to travel there over time, I'm going to see an increase. I have seen that actually. I've been going for about 15 years, and I have seen an increase in the caries as the soda industry invades. Arginine is going to be something to watch out for in the future. Arginine, they're putting it in toothpaste. I think Colgate-Palmolive has one. It actually raises the pH because of an arginine deaminase system. So you want to watch out for that in the future. So that'll be something fun to watch. Silver diamine fluoride is something else you're going to want to watch. It's out there. It's in use. It is so fantastic, and it actually stops decay. The only downside is it does turn the decay dark, and so you have to manage that very carefully. There is a great technique of using glass ionomer fillings on top of silver diamine fluoride, and that really mitigates the coloring. You'll want to read a little bit more about the use of SDF and how powerful of a tool it is, the silver diamine fluoride, in stopping decay. This is a picture of how it looks. You can see it initially turns it dark, but then you can cover it up with glass ionomer. And especially for primary teeth, this is a very powerful a very powerful tool. And once again, I'd suggest you put a little fluoride varnish over this when it's done. So favorite messages real quickly before we get to our questions. You don't want to replace the roof without putting the fire out. Prevention is all about, just like telling a good joke, it's about the timing. Timing is everything. It takes 20 minutes for your saliva to neutralize an acidic environment. So, that if you're snacking all day, that your mouth is constantly in an acidic environment. Spit is your friend. You want to really help your patients develop an appreciation for it. I use some simple messages. I've created a nice little brochure for my patients that give a lot of the talking points I've included in this webinar. If you email me, you can get a copy of it. I'll send you a copy for free. You can customize it. I want them to understand that some foods might be good for their body, but actually create too much acid challenge for their teeth. This is part of that communicating non-judgmentally. You want them to become their own diet detective, understanding that there's good, bad, and ugly carbohydrates, and really understanding their own oral ecology. I want them to think about thoughtful eating versus grazing. And we always have to focus on that in a non-judgmental way. The team approach is what works best. And so you want to encourage all this messaging to come from every member on your team, that they're all on board with the same message. Other prevention-centered practices, again, placing fluoride varnish on a glass ionomer restoration when it is placed, keeping an eye out for toothbrush abuse, using GI and SDF, and special visits to look at hygiene checks, and making sure that all recalls are appropriate for their risk level. How do I know if Cambra is working? We have about 30 new patients per month in our practice and over 500 recall appointments per month. And year after year, we are voted the best of Nevada County where we live. And that makes me feel pretty good. We have a good staff retention. Our team has been together for years, and that makes me feel good as well. How can you make your prevention more cost effective? You might consider having a universal fee that includes your fluoride varnish in it at your Profies. They're much less expensive than fluoride trays, which of course very few people use anymore. But the cost of prevention versus restoration is clearly a win-win. You want to make sure that patients understand that value. So compared to a restoration, prevention is actually a real bargain. Remember, you can't save every tooth. You can tell patients all you want about prevention. It doesn't mean they're going to do it. Not everyone is going to invest the time to improve their own oral health. You can lead the horse to water, but you can't make them drink. And then my last little tip is to make sure you save the thank you notes for your own salvation and your mental health, because you're going to, all within one day, you might feel like you're the greatest dentist, the greatest hygienist assistant there is. And then within that same day, you're going to feel like a dog. So make sure you save your thank you notes and read the messages from your patients who appreciated your care. It'll help you keep your own sanity. So with that, why don't we get to our questions and answers? I'm sorry we went a little long here. Let's see if I can answer these. Jennifer asks, how do you feel about probiotic lozenges? And I'm very curious. I have not heard of this yet, and I want to go look that up. So I'm glad you mentioned that. There's another question from Gordon. Isn't fluoride beneficial systemically when the permanent teeth are forming? And actually, Gordon, that is not the case. I mean, they understand that that's not the case anymore. That through studies that found there is a slight benefit for systemic when the teeth are forming, but the effect on the permanent teeth is from chewing those fluoride tablets. It gets stuck in the grooves, and it's a topical effect. Manali asks, how often do we put fluoride varnish on class 2 cavities? Well, it depends. If it's a class 2 cavity, I would think that you would have the patient brushing. If you're trying to reverse it, you would have the patient using a high fluoride toothpaste at home and possibly dipping a interproximal brush or running their superfloss through that high fluoride toothpaste, and then having them come back every 3 months for fluoride varnish applications. Brandy asks, please let's not give up on the research of the patients that need constant suctioning. It's something my coworkers and I talk about all the time. Oh, I totally understand. So Jennifer asks, what fluoride toothpaste do you use? I use ClinPro, and sometimes I buy the high fluoride toothpaste. And I use the Centrix varnish brand, which I really like, the Fluoridose. They have been extremely generous in donating supplies when I go over on my Uganda trips, and that's what kind of acquainted me with how well their product works. And it's a slow release fluoride, which is also important. You don't want the fast release fluoride because that will actually it will dissipate too quickly. So I think that might be all we have time for. Maybe I have a couple more minutes here. Leon asks, what's your view of fluoride, silver fluoride, SDF? I've seen dark silver deposit become a positive behavior motivator. Yeah, I have no problem with it. And from what I know, parents are actually very accepting of silver SDF treatment, even if it makes the child's teeth dark, because it can help avoid the need to put the child in the OR and have them go under for extensive restoration. So if you look at the risk of knocking a kid out for, in the OR to treat their caries, if it's a 3 or 4-year-old versus having dark teeth, I think I would much rather have my child have some dark stains than have the health risk of being put under. Bonnie asks, I had a new patient today who asked if the pre-rinse had fluoride in it and requested I use fluoride-free polish. She's asking, what do we do with these patients who are fluoride phobic? And we can only educate. And then there is a MI paste product that is fluoride-free, but at least has the calcium and phosphate. I would just say gentle, continued education and offering them alternatives. It's not as good. They have to be aware of that, but at least it's some increase in mineralization. Oh, yes, and Gordon wants me to remind the audience that xylitol is deadly to dogs. Yes, thank you. You're absolutely right. So, okay for people, The bacteria don't like it, but it's deadly for dogs. So be careful if you're a dog owner. Tabitha wanted me to go back to the intake form. I can't really do that in this form, Tabitha, but if you go to the Centric site or the ADA, you will find a great intake form. And I think that's all we have time for. I really appreciate you being here today and sharing this learning session with me. And again, you can see my email address. If you email me a question, I will do my best to answer it. So thanks again for joining me, and I wish you luck going out there being prevention coaches.